I'm Dr. Sasikala. Good morning, dear teachers and my dear colleagues. I thank the scientific committee for this opportunity, for giving me this chance to stand in front of you to present this. Yeah. So today my part is to cover on biometry and IOL power undercorrection. I have no financial interest. So as pediatric ophthalmologists, it's indeed a big challenge for us to calculate and select an optimum IOL power for the growing eye of a small child. So this is a complicated decision-making process for us. So the accuracy of IOL power calculation, it has not shown a similar amount of improvement which has happened with the surgical technique. And the formulas that we use for the pediatric group are ideally designed for the adult eye. So there are only fewer evidences that are present that tells us the accuracy of the IOL power in these pediatric eyes. Again, compliance to amblyopia therapy is a big question, and a long-term follow-up is required in these children. And children, we know they are less cooperative for in-office measurement, so there is a requirement for us to do an evaluation under anesthesia, which raises a lot of possibilities of errors. Just briefly on the growth of the normal eye. So as the child grows, so from birth as an infant to late childhood, till 13 years of age, there is an increase in the axial length, we know, from 17 to 24 millimeters, and the lens span starts gradually reducing down from 34.4 to 18. Gordon and Donsel, they had shown that 90% of the growth gets completed in the first 18 months of birth. So what happens after a fixed IOL power is placed in an eye of a child which is growing? So following a cataract surgery, there is loss of natural lens. So there is disturbance in the emetropization process. So every millimeter axial length grows, there is a 2.5 diopter change in the refractive error. So there is a gradual shift towards myopia. So postoperative refraction is based on the initial undercorrection that is made. There are two standard approaches. One is either you choose for an initial hyperopia or later emetropia. In the initial hyperopia, the child requires to wear hypermetropic glasses and requires to comply for amblyopia therapy. We aim for emetropia later in childhood. When we aim for initial emetropia, the child develops myopia in later adulthood. We'll have to plan an IOL exchange or refractive surgery later on. So what is the process for us for biometry in these children? So initial, for us to calculate IOL power calculation, the first step is to do a proper biometry to calculate what is the IOL for the emetropia. How much to undercorrect is the next step, which depends on multiple factors. So based on the age. So younger the age, younger the child gets operated, so we have to aim for a larger amount of hypermetropic correction. Laterality, again, bilateral cataracts, we can aim for a full amount of hypermetropic undercorrection so that equal refractive error is given for both the eye. Based on the vision, if a child has already expected to have a dense amblyopia, if the vision is low, we would expect the child to comply very less for amblyopia therapy. So better for us to aim an undercorrection which would give lower amount of hyperopia or almost emetropia. So child in the initial treatment years will comply better for amblyopia therapy. Later on, if the child develops myopia, late myopia can be managed later on. Then based on the fellow eye, so if the fellow eye is pseudophakic or fellow eye is phakic, based on the refractive status, we can plan for the undercorrection of the present operating eye. Then if the parents or sibling are high myope, again we can plan for a larger amount of hypermetropic residual refraction. So if in case the child moves into myopia, that would not be a larger extent of myopia. Finally, if the compliance to amblyopia therapy is doubtful, compliance to glasses, contact lens is doubtful, we can aim for lower hyperopia or almost emetropia. Then finer adjustments can be made if there is a change in the site of fixation. If we choose for a ciliary sulcus, 1 to 2 diopter reduction based on the initial IOL power, we could decide. So we all know that axial length measurement either could be done with optical biometry, partial coherence interferometry method, lens star, or with IOL master, and ultrasound biometry traditionally by either a contact or an immersion method. Just I'm playing a video just to demonstrate the techniques. So contact method needs to be done soon after the initiation of anesthesia, induction of anesthesia without eye speculum, and we should make sure that there is no indentation of the cornea because falsely lower axial length could be made, and most of the errors happen with contact technique. EUA with immersion technique is the ideal method for calculation of axial length. So there is a probe that is placed and there is a coupling fluid between the tip and the cornea. IOL master is used for cooperative children as an office-based measurement. Manual keratometer could be used for cooperative children, more accurate. Handheld keratometers under EUA. Only thing, the problem is there is no fixation, so steady fixation, central fixation is not there. So we need to be careful about it. So repeated measurements are advisable, and the cornea should not be dry while measuring. There are other newer keratometers with autorefractometers handheld that are also available, which have good lighting, and it has melody functions in it, so that it could be easy for children to cooperate. Coming on to sensitivity of IOL power calculation to axial length and K reading. Shimoni et al., when they studied the axial length measurement between adult and children, they found for adults, for every millimeter error in the axial length, there is depicted 3 to 4 diopter error in the IOL power, whereas for children it is 4 to 14 diopter error in the IOL power. Trivedi et al., they studied the keratometry measurement errors and found that for every diopter error in the K reading, 0.8 to 1.3 diopter, there is an error in the IOL power. Mittelby-Haas, when they evaluated the error in keratometry in infants, they found that lack of fixation in children is the main reason for inaccuracy. So the deviation could be up to 6 diopter. The other studies, Benzion et al., when they compared the methods of biometry between immersion and contact, they found there was no significant difference in IOL prediction, whereas Garziu et al., they reported axial length measurements that were made through contact method were 0.24 to 0.32 millimeters lesser than what is done with immersion. So they recommended repeated measurements where there is 3 equal measurements with sharp retinal spikes. So instrumentation error in normal eye will result in 2.5 diopter for every millimeter error with the axial length, whereas for long eyes is 1.75, whereas you can see for the short eyes is 3.75 diopter. IOL power calculation, it's a controversial topic. There are no formulas that are proved accurate till date, and the arena of formulas that we have is SRK-T2, Hoffer-Q, Holiday 1, 2, and pediatric IOL calculator. Theoretical formulas are more accurate for pediatric eyes. So which formula to choose? So various clinical studies have put forth. Miser et al., they studied 5 IOL calculations and they found none of them were satisfactory, and SRK2 proved fair to good agreement. Neely et al., they analyzed the IOL calculation errors and found newer theoretical IOL calculation formulas did not outperform older regression ones, and each formula demonstrated a high degree of variability. SRK2 had the least variable. Nihalani et al. Reported that Hoffer-Q was predictable with the pediatric small eyes. Epsheets et al., they found Holiday 1 and Hagees to be similar in IOL power prediction. SRK-T was comparable with Holiday 1 and Hagees. Cora et al., they concluded that all the formulas were less accurate in axial length of 22 and less. SRK formula had the best predictive error for compared to the SRK-T and Holiday formula. In 2016, published in Eye Journal, Vasavada et al., they performed a prospective study under 2 years of age. They reported SRK-T and Holiday 2 formula with best predictive error, and personalization of IOL constant did not affect the predictive error of the formula. So when we determine the target postoperative undercorrection, it should be a stepwise approach. We should consider the age and the projected growth of the eye. What is the ideal IOL power that has to be implanted? That should be one that can fight amblyopia, at the same time produce a least refractive error in childhood, anticipating myopic shift. There are various guidelines providing us how much to undercorrect. So Dahan's criteria, the most popular, 20% for less than 2 years and 10% from 2 to 8 years of age. The other table is based on the IOL axial length. There are various guidelines. Ennedy et al., Plager, Crouch, Trivedi and Wilson et al., they have also provided us the table, how much to plan. This is based on the age of the child, how much of target refraction. So in 2018, a study done from Bangkok by Lexcool et al., published in Clinical Ophthalmology about the long-term outcome of intended undercorrection, intraocular lens implantation in pediatric eyes. They had made a table of undercorrection based on the Gordon and Donzel's prediction on the axial length growth keratometry reading, starting from 6 months of age to 10 years of age. So in their study, they had found that out of 84 children in their eyes, in their study, 45 eyes were myopic, and the mean refraction was minus 2.26 diopter. They concluded that 5% more of increment needs to be added for each group so as to avoid late myopias. So we are sharing our experience with the Dahan's criteria, which was published. We looked into the long-term outcome in children operated for cataract with IOL less than 2 years of age. We had a 6-year follow-up. So we had 39 eyes with a 6-year follow-up, and we found that the mean spherical equivalent at the time of study was minus 1.02 diopters. Mean myopic shift was 5.91 diopters. We had 46% with final visual acuity of 0.47 logMAR 2060. And we had 3 eyes who had to undergo an IOL exchange for large myopic shift at 9 years of age. And a comparison, when we compared between 12 months and 13 to 24 months of age, we had a myopic shift and visual acuity, which was highly significant. So presently, now we are following the guidelines of Trivedi and Wilson et al. So at present, the acceptable age for IOL power implantation has been reduced even as younger as 2 months of age. So the modified and the current recommendation by AAO guidelines starts from less than 1.9 months of age, and 4 powers are given for target refraction, and later on till 14 years of age a detailed table has been provided in the AAO guidelines. So how much to undercorrect? From the observation studies what we see, Sachidev et al. In 2017 in American Journal of Ophthalmology, they had seen that most of the children achieved an acceptable final refractive error using the guidelines of NED et al. There was a myopic shift that was seen higher in 0 to 2 years of age and least in 4 to 7 years of age. Jesman et al., they compared the SRK2 and the pediatric IOL calculator group. They found no statistical significant difference found in predictive error and accuracy of predictability of postoperative refraction between the 2 groups. IOL calculator is a new tool for us, but word of caution, there are very fewer studies that are present about the predictability and accuracy of IOL power calculator, and this present study also has a very small study group of 15 eyes only. So to conclude, so the IOL power that has to be placed that's very ideal for the child is that which fights amblyopia and that is least refractive error in adulthood. And it has to be a case-based customization when we choose. So there is no published table for IOL power selection, and all formulas are unsatisfactory. For shorter eyes, we could choose Hoffer Q, and SRK2 has least variable in the pediatric eyes. Despite our best efforts, some children will definitely, maybe later on, require an IOL exchange or refractive surgery. So IOL in very young children, we recommend a long-term follow-up to tackle myopic shift. Thank you so much.